I'm now pleased to introduce our first speaker, Richard McKeon, Chief of the Suicide Prevention Branch of the Substance Abuse and Mental Health Services Administration's Center for Mental Health Services. Dr. McKeon is a passionate mental health advocate who has dedicated his career to improving mental health at the community level. He served as director of a psychiatric emergency service for 11 years and was awarded an American Psychological Association Congressional Fellowship, where he covered health and mental health policy issues for Senator Paul Wellstone. He also served on the National Action Alliance for Suicide Prevention and took part in the process of revising the National Strategy for Suicide Prevention and developing the World Health Organization's World Suicide Prevention Report. Today, we're grateful he's with us to provide an overview of current data on suicides, as well as an overview of federal suicide prevention efforts. Dr. McKeon?
Thank you so much. It's a pleasure to be here speaking with you all. So I will go over a couple of key issues and we'll give an overview of some of the concerning trends about suicide that we are seeing, but also about some of the things that we know we can do in response that can save lives. So the views that expressed here don't necessarily reflect the views of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. So just want to make that disclaimer. So as was kindly mentioned in the introduction, it is important to be aware that the United States does have a national strategy for suicide prevention that SAMHSA, as well as other federal partners, are working together to implement. The national strategy is basically a document that summarizes a comprehensive approach to suicide prevention. We know that if we simply wait for people who are at risk to show up in the offices of psychologists such as myself or a psychiatrist's office, then we're not going to be able to halt the rise in suicide that's occurring nationally. We know that we need a comprehensive approach that engages multiple sectors and many people with them, as we all have a role to play in suicide prevention. And part of the reason that that is so important is clear when you look at what the trend has been nationally. Last year, the CDC issued their vital signs report indicating that suicide was rising across the United States and that it was more than a mental health concern, also clearly involving substance use and abuse, but also a range of other factors as well. So in virtually every state, in fact, 49 of the 50 states, suicide increased over a 17-year period from 1999 to 2016. And in fact, in half of those states, the increase was greater than 30%. So the slide that you see in front of you, gives you an idea of those increases. And the only state where suicide did not go up during that period of time was the state of Nevada, which started off with one of the highest suicide rates in the nation. And they did see a decline of about 1%. Suicide is a leading cause of death really across the lifespan. And as this slide shows, it's actually the second leading cause of death from age 10 to age 39, trailing only accidents as a leading cause of death. After that, suicide drops as a leading cause of death to fourth between ages 40 and 49, and seventh between ages 50 and 59. That doesn't mean that the rate of suicide actually goes down during that period of life. In fact, it actually goes up. But other causes of death, such as cancer and heart disease, are increasing at even a greater frequency, which is why suicide drops as a leading cause. But still, as you can see, very significant, fourth and sixth. It's also important to be aware of that deaths by suicide are very similar in number to deaths from opioid overdose. Opioid overdose fatalities are about 47,700, and suicides are about 47,100. So they are really twin scourges that together have been contributing to the decrease in longevity for Americans. It is also important to remember that while every death by suicide is tragic, suicide deaths do not represent the full extent of the problem of suicidality. There are many suicide attempts. Thankfully, the majority of people who attempt suicide do not die by suicide. The slide in front of you shows the variation by age, and actually, suicide attempts are more frequent among young people. SAMHSA's National Survey on Drug Use and Health estimates that about 1.4 million American adults age 18 and over attempt suicide. In addition, that same household survey estimates that over 10 million American adults seriously consider suicide each and every year. So that is, thankfully, all those who seriously consider suicide don't attempt suicide, and not all of those who attempt suicide die by suicide. Otherwise, the numbers would be much higher than the tragic toll that it already takes. But it also shows you how broader the issue of suicide risk is. The next slide is from our colleagues at the National Institute of Health, and it shows you annual suicide deaths. That's from back in 2016 data, as well as annual suicide attempts. And they did this to identify potential settings and ways that intervention could take place. So you can see over 21,000 of those who died by suicide were seen in an emergency department in the past year. 20,000 accessed health care. 22,000 were deaths by firearms. Typically, firearm deaths have been about 51% of the total number of deaths. You can also see for suicide attempts some of the numbers: 110,000 in those in substance use treatment, 410,000 in outpatient mental health treatment, just as examples of that, indicating places where we can potentially intervene. I'm not going to be able to give a full rundown of all of the federal efforts to reduce suicide, and they are many. And my colleague working from the Veterans Administration will be talking about VA's efforts. This slide is just to give you a quick rundown of SAMHSA's efforts, which include our Garrett Lee Smith State Tribal Youth Suicide Prevention grants, which at this point at least one grant has gone to every state. And our evaluations have shown that counties that were implementing grant-funded activities had lower rates of suicide and suicide attempts compared to matched counties who did not. We also have a campus suicide prevention program. We have what's called the Zero Suicide Initiative, which is really acting to try to strengthen suicide prevention in healthcare systems. We have a National Resource Center. We have what are called national strategy grants. We have a large program in tribal behavioral health that focuses on suicide prevention and substance abuse prevention, called Native Connections. We have the National Suicide Prevention Lifeline, which last year answered more than 2.2 million calls, and 25% of those calls were from people who are actively suicidal. And we're working together with the Veterans Administration, what are called Mayors and Governors Challenges, to reduce veteran suicide in cities and states. We're also in the process of preparing a toolkit for families where there's a loved one who has who is at risk for suicide. Let me tell you a little bit more about Zero Suicide. And this is an effort that really was inspired by the success of the Henry Ford healthcare system. You can see the slide in front of you that after they launched what they called their Perfect Depression Care Program with a goal of zero suicide, they were able to substantially reduce suicide deaths among their HMO members. In fact, they had 6 consecutive quarters without a suicide death. So zero suicide doesn't mean no suicide ever again. What it does mean is that we give our best efforts to reducing suicide. And each month that goes by when there is not a suicide, that we celebrate that, because that is what we are hoping our health systems will be able to help do. In addition to the findings at Henry Ford Health System, others at places like Centerstone, one of the nation's largest nonprofit community mental health centers, and in the Missouri Community Mental Health System, have found similar results in terms of reductions of suicide deaths among people in their care compared to those who to other systems. Another area that SAMHSA has really worked on across all of our programs is improving care transitions. There are lethal gaps in many systems. The period after inpatient unit and emergency department discharge, which is typically where people at acute risk are sent, is one of extremely high risk, particularly the first 30 days. Wallenstein et al., in a study of over 1 million veterans being treated for depression, found that the period after inpatient discharge was the period of highest risk. Too often the rates of follow-up care are poor, yet intervention during this time has been shown to save lives and reduce suicidal behavior. And for this reason, we make this a requirement in virtually all of our suicide prevention grants. This slide, again, just shows you the risk of suicide in the 90 days after hospital discharge, broken out by psychiatric disorder. This slide shows you the results of a study done by the World Health Organization in a number of different countries, 5 countries. It was a randomized control trial, and it showed that those who received a brief emergency room intervention and, importantly, follow-up telephone contacts over the next 18 months had significantly lower rates of death by suicide, and in fact, actually had lower rates of death from any cause, which shows the importance of our service systems trying to incorporate this. One of the interventions that is now being used in multiple settings, in mental health settings, in emergency rooms, and in primary care offices, is what's called a safety planning intervention. It used to be that mental health professionals relied on what were called no suicide contracts, where somebody would kind of pledge that they wouldn't kill themselves in writing. And not only was there no evidence that that worked, there was actually evidence that it was harmful. Safety planning has been shown to reduce suicide attempts in controlled scientific trials, and is basically a way of working collaboratively with a person about what they can do to keep themselves safe. So it's all about what to do, not about what not to do. This is another resource that's available on the SPRC website as well as on the Zero Suicide website. It's on counseling on access to lethal means. So this is to help providers understand how they can talk to individuals and family members regarding access to lethal means, so that in a moment of acute distress, there's not accessible lethal means, because if a person can get beyond those critical moments, they might well survive. This is another resource that focuses on structured follow-up and monitoring, also available at the Zero Suicide website. SAMHSA has also been working actively to try to improve crisis services in the United States. The Crisis Now model basically talks about what's called a call center hub. Basically, the idea that just like in air traffic control, there's always somebody who knows where the airplane is. That in the United States, when somebody's at risk and they contact an acute care service, somebody should always know where they are. They shouldn't be lost to contact in the days or hours following discharge. Also, the idea that there is mobile crisis intervention, a team that can go out to where the person is rather than necessarily the person having to go to the emergency room, as well as that there are crisis facilities, short-term crisis stabilization facilities, typically 72 hours. These are some of the things called for in the Crisis Now model. Now, the reality is that ubiquitous and inexpensive technology is changing nearly every other industry. It is clear that the technology exists for us to be able to stay in contact with people who are at risk, and that it's important that we should be doing that. It should not be acceptable in the United States of America that in our healthcare systems we lose contact with people after they leave an emergency room or an inpatient unit. And some healthcare systems are doing wonderful work in this regard, but there's tremendous variability across the United States. You should also be aware that currently the work is being done on the National Suicide Hotline Improvement Act, which was signed by the President in August, and that this act calls on the FCC, the VA, and SAMHSA to work together and to speak to the advisability and feasibility of a national 3-digit N11 number for suicide prevention. So like 911 for emergency health care, a 3-digit N11 number for mental health crisis and suicide prevention care is what is being examined there. The FCC's report is due to the Congress this coming August. I mentioned our youth suicide prevention efforts under the Garrett Lee Smith Memorial Act, which has shown that counties that have been implementing this important work have lower rates of youth suicide deaths and attempts than match counties who have not. And I also wanted to make sure that I highlighted some of the work that we're doing with our colleagues from VA, and you'll be hearing from VA shortly. It's called the Mayor's Challenge to reduce suicide among our nation's veterans. You can see a listing of the cities participating in the Mayor's Challenge. We are also doing similar work with the nation's governors. And there you see the states that are participating in that. And actually, the National Governors Association just came out with a series of recommendations for states that you might be interested in. And I mentioned the National Suicide Prevention Lifeline, which last year answered more than 2.2 million calls. In many places in the United States, if it's in the middle of the night or even on a Sunday afternoon, the only options if someone needs immediate help may be the lifeline or to go to the local emergency room. So I'm going to end there. Here are some key resources. You have the Lifeline number, our Suicide Prevention Resource Center at www.sbrc.org, and the Action Alliance for Suicide Prevention at www.theactionalliance.org. Thank you for your time and attention.